Would you like the senior discount? No. And some of my patients realized they were old at 60 or 65. Others not until they were 85. Some until they had to confront being unable to do something they could do previously. And God knows one of those things is being able to drive. Things change. So, the question here is dementia the cost of a long life expectancy? You know, our grandparents, our great-grandparents didn't have to deal with it. But we all knew someone who was, quote, senile. But it might be an interesting fact that I graduated from medical school in 1975, Temple University. And we did not get anything in lectures about Alzheimer's disease because, quite frankly, Alzheimer's did not come back into curriculum until '82. We heard about senile dementia and pre-senile dementia before 65. But we learned nothing about AD. And it was about 1982 that some papers came out looking at the brain pathology of pre-senile dementia and Alzheimer's classic paper from the early 20th century, that we began to realize it's the same disease. And that has some import a little bit later on in this talk. The single greatest risk factor for a dementing disorder, with a few exceptions, is living long enough to get it. Increased age is the major, certainly for Alzheimer's, increased age is the major risk factor for developing the disease. The longer one lives, the more likely one is to develop it. By the age of 85, the risk is about 40%. The signs and symptoms, of course, fall on a spectrum, and many people with dementia, even with Alzheimer's, die without really being diagnosed, and they continue to manage on their own. The majority of patients with Alzheimer's do not live in nursing homes, they live at home. Some of them alone, some of them with a lot of help, some of them with family. So what is dementia? This is one of the definitions by Frank Benson and Jeff Cummings, two wonderful behavioral neurologists. And they note that it's an acquired and persistent illness. No one is born demented. It is not mental retardation. But it impairs intellectual function in 3 of 5 domains. What's good about this definition is memory is not given particular primacy. The other definition by the behavioral neurologist Marcel Messelon notes that it is a chronic and usually progressive decline in intellect or comportment. Comportment, a wonderful old word that used to appear on our report cards. Behavior, personality, mood. They're the missed parts of dementia. But the person's life, their customary ways of living become gradually constricted with time. What are the etiologies? What are the causes of dementia? Nomenclature is very important. Alzheimer's is a specific form of dementia, but not all dementias are Alzheimer's. And when I was practicing at Georgetown in the geriatric psych clinic, I was the only geriatric psychiatrist there, so it's insane to call it a clinic. It was my office. I make a diagnosis of dementia, and someone would invariably say, "Oh, thank God it's not Alzheimer's." I've got to work on my communication skills here. It's rather like saying chocolate cake. Chocolate cake is a generic term, dementia. But German chocolate, Black Forest, and triple death by fudge are 3 different kinds of chocolate cake, which mean different things. The most important thing, which I'm not going to dwell on, is the neuroanatomy of the lesions is the determining factor in how the disease is going to present. And that's up to the experts, and we're still elucidating that now that we're so much more able to study the thinking, the acting, and the living brain, as opposed to the need to diagnose with a post-mortem. This is a list of the various etiologies of dementia, broken up into a variety of different subgroups: vascular, infectious, neoplastic, degenerative, inflammatory, and so on. What are the inabilities of dementia? Look at this slide. This is not an official one. I was sitting one day with Psalm 90, 70 years and 80 for those who are strong. I began just writing down loose associations of what my patients with dementia couldn't do. Now, each patient will present individually with these losses. They don't occur in any particular sequence, and some people maintain some skills much longer than others, both within themselves and when compared across groups. I had a patient, Eleanor, lovely woman, lived a block away from my office where I practiced internal medicine, and she eventually developed pure classic Alzheimer's. And eventually Elmer, her husband, couldn't care for her. She went to a nursing home. And I got to see her once a month as per Pennsylvania law. Went in one day and I heard the people in the dining room singing things like The Old Gray Mare and Put On Your Bonnet, Nellie, and all those great old songs. And I asked the nurses where Eleanor was, and one of them grinned and said, she's in the dining room. I went in the dining room, and here's a woman who did not know her children's names, wasn't sure who her husband was, had no clue who I was. And she'd known me since birth. But there she was the one playing the piano perfectly, and she was using one of those books that have the melody, but she was throwing in the chords herself. Why could she do this? 50 years she was the organist and pianist at the Methodist Church across the street. And it wasn't until a stroke that she ceased to be able to do that, even though she could hardly care for herself and certainly couldn't solve problems or multitask. The prevalence of dementia is a function of age. It doubles every 5 years from the age of 60 to 90. It's about 1% in patients 60 to 69, 2%. By 90 to 95, we're looking at around 40%. And no matter what statistical manipulations are applied, the curve on the graph here does not change. The y-axis is the percent of patients with dementia, the x is the age, ending at 105. So it just goes in one direction. It goes up. The Cache County study is focusing on a Cache County in Iowa. It's being run out of Johns Hopkins, and that 70 to 75% of individuals at the age of 100 would develop dementia if they were tested, and if we knew how to do the testing. Breitner, one of the men, expressed a very significant concern here that perhaps dementia, which he calls Alzheimer's, is part and parcel of aging. The only difference being the age at which it has its onset and the speed with which it progresses. Dementia is both a disease and an illness. The two are not synonymous, because a disease comes from a very biomedical perspective, and it's concerned with the pathological changes in an organ or in an organ system, or all of the organ systems that eventually become involved by the disease. An illness is a sociocultural perspective, and it looks at the perception and the experience not only of the identified patient, but as an illness progresses, of the family and the social milieu, the community, perhaps the workplace. For those of us, I live with 80 old Jesuits. And so when one of the men becomes increasingly ill, it's going to affect the entire community. Dementia is incurable, but healing is possible. And this is where a lot of the work of hospice is translated into routine, humdrum medical care. We learned a great deal from pioneers like Cicely Saunders. A cure implies the reversal of a pathological organic process, or remission or stabilization. Acute disease is curable. Chronic ones are not. Surgeons cure a lot of diseases. They remove the appendix, they remove the tonsils, stuff like that. Internists cure some diseases, but a lot of times we're stabilizing diabetes, high blood pressure. You don't cure those in most cases. Then, of course, we come to psychiatry, and we just find out how do you feel about it. Healing, on the other hand, is the restoration of meaning. It restores meaning to one's life, perhaps to the amount of life one has left. Healing occurs despite illness. How many miracles, healing miracles, have been declared at Lourdes in about 150 years? Anyone want to throw a number out at me?
67.
It's a little higher than 60. It's around 118, I think. I don't know if any new ones have been declared. How many people go to Lourdes a year? 100,000 is probably low. A lot. How many people are healed at Lourdes? Many more than are cured. The healing, the looking for peace, acceptance, that's what happens. That is sometimes the miracle. A very touching story is a young couple, they're both physicians. I treated the husband's mother who had Alzheimer's. He was an orthopedic surgeon, daughter was family practice. And the daughter, they had 5 children. And the woman, the daughter, was dying of gastric cancer. And one day she looked around, she was quite ill at this point, a few weeks from death, and she said, "This is the miracle. Not that I'm dying, but we have these children." That's healing. That's not a cure. The illness aspect of dementia is very much sociological and existential. Our culture is overwhelmed by expectations of rationalism and productivity. Who are you? What do you do? How much do you make? They're pretty big questions. And we take great pride in our cognitive ability and our productivity because that influences our sense of self-worth. Why do some college professors teach beyond the age of 85? Because the professor can no longer tolerate the idea of not being the professor. There are a lot of ethical dilemmas that come up here. And it's the real point of contention in geriatric psychiatry. We have to make a demented physician stop practicing for the safety of his or her patients. But the real problem, and I'm sure many of you in this room have faced it, when do we pull mom or dad's driver's license? Too late, yeah, sometimes. My mom was a wonderful driver, much better than my dad. And when she was about 85, 86, she called me one day and said, "Guess what? What? I decided to stop driving." I said, "Well, what prompted your decision?" He said, "Well, I have neuropathy in my feet, and I can't tell if my feet are on the brake or the gas. And I don't want to hurt someone." So we talked a little bit more, and then we hung up the phone, and I went, "Yes!" I didn't have to have that conversation with mom. Thank you, Jesus. So our cognitive ability, sometimes we have to intervene. And this is the hot, nasty of it. Does the person's independence and right, quote unquote, right to drive, trump our right to safety on the roads? The value of a person is not diminished by cognitive decline. We have to remember that. Certainly, I have to remember that at the community. When I see men who are incontinent, who are nonverbal, but yet I know what they did as young Jesuits, sometimes under the worst of circumstances. I walk on the same steps that they ran up and down as scholastics. And now they can't find their way around the building. Does it diminish their human dignity? Should we off them? A little injection at night, and plan the funeral for a Tuesday, which is convenient. We've got to assume equal moral standing toward those who can no longer remember. And one of the tasks of ethics of conferences like this, of the work that Andrew's doing and others, is to secure the underpinnings of care for those who are affected by progressive dementia. When I was in med school, the big fear was cancer. In 1971, cancer. Raging debates, do you tell a patient he or she has cancer? Well, that debate is long since dead. But with dementia, it's still a debate. And certainly, as pointed out, one of Hopkins' first patient was a woman with moderate dementia who was obviously going to progress. So let's look at two ethical dimensions of dementia and a little bit of practical advice, too. There's got to be a take-home message here. The first of these dilemmas is in the arena of medication. Now, it's important to recall that the first medication aimed at treating, quote-unquote, sarcastic tone of voice, the changes of Alzheimer's, was released in 1993. It's called Cognex. Its generic name was Tacrin. I worked in the VA hospital at Dartmouth at the time, and only one neurologist was allowed to prescribe it. So anyone I saw in my clinic who I thought might have early Alzheimer's disease had to be referred to the neurologist who would reevaluate and determine if to use Cognex. Well, Cognex is no longer on the market. It was not terribly effective, and the side effect profile was dreadful, particularly for the liver. It's very difficult to take, very unpleasant medication. Was it effective? Are the medications we're using today, the sons and daughters of Cognex, and I just forgot all their names. Embarrassing. I'm 18 months away from Social Security. Are they any more effective? There was an interesting first-person narrative in one of the national magazines when Cognex was first on the market. And it was a woman who said, I know the medication is working, because now I can sit and read to my husband for an hour, and we can go for long walks. My question then, as it is now, is, was this a placebo effect for you? By thinking the medication was going to really improve things, you were doing things that you hadn't been doing previously. And we know that socialization is one of the most important things, even for the very, very demented. And what I find ethically suspect today, if not infuriating, is the advertising, both in print and on television, showing things such as, my dad has come back, after putting on a patch. And then you see, a husband and wife snuggling a little bit, or the perfectly coiffed daughter walking down the autumn leaves with her father. How come in those pictures you never see the dad who's come back because of the patch driving down the JFK Expressway with the daughter as a passenger? Because it ain't going to happen. So we have to wonder, what are the ethics of promising something that is not going to be delivered? The medications may slow down the slope of the curve. The medications may delay the need for institutionalization by a matter of months or maybe a year. They are not curative. And too much advertising is suggesting that we're going to get things back to the way they were. Cue Barbara Streisand. But the fact is that the medications are not terribly effective. Now, this paper appeared in the New England Journal of Medicine on August 30th, 2012. Clinical biomarkers changes in dominantly inherited Alzheimer's. And I bring this up for a particular reason, to tell you about the difficulty of developing medications or other treatments for Alzheimer's. This study looked at a very tiny portion of patients who have familial transmitted genetic Alzheimer's. Like Huntington's disease, if you have the gene, you get the disease. And for the familial forms, which is related right now to 3 different genes, we have a pretty good idea of when the expected onset of symptoms would be. based on when the symptom onset occurred in the parent. So the study was able to take patients at any number of ages from quite young to maybe getting close to symptomatic, running through a number of various biomarker studies to try to get an idea of what are we seeing, and what the results were really kind of terrifying. Because there was evidence in the cerebrospinal fluid of a decrease in the amount of amyloid 25 years before the expected onset of Alzheimer's. PET scanning was detecting the deposition of amyloid 15 years before the onset of symptoms. Impaired memory testing on high-level neuropsychological testing was apparent 10 years before the onset of symptoms. More global cognitive impairment on testing was apparent 5 years, and a diagnosis of dementia was made somewhere within 3 years of diagnosis. Thus, we come up with the ethical dilemmas that if a medication were available, when do you start it? 25 years, 15, 10, prior to expected onset. And that's only for a tiny, tiny, tiny 1% subset of possible patients. Suppose we could accurately determine everyone at risk for Alzheimer's 30 years before diagnosis. How many would want the test? Who wants to know the future in that way? Now, I once thought I could make a really good living as a medium. Because besides saying, tall, dark stranger and all that stuff, that, oh, I see, someone in your life is affected by Alzheimer's. Maybe a family member or a close friend or a loved one. And it hurts you. $100 right there. Trust me, I'd ignore the vow of poverty on that one. Wouldn't turn it in. So we're looking, and we know from the experience with Huntington's disease, the gene responsible for Huntington's was discovered at Mass General sometime after 1993. I think it was around 1997, 1998. Many fewer people at risk for Huntington's have been tested than was expected. I evaluated a woman in my clinic with Huntington's. She has 2 daughters. And if you have a parent with Huntington's, 50-50. Woody Guthrie died of Huntington's. His son Arlo, of Alice's Restaurant fame, did not inherit the gene. So one woman who was the custodial caregiver for her mother, a lawyer, refused to be tested. The other sister was found to be negative. I also once celebrated a wedding for 2 young doctors, and the bride's mother was becoming symptomatic. The bride's sisters were tested. She absolutely refused. So we are raising the question of the ethics of checking and determining a diagnosis decades before the onset. How many insurance companies would love to get their hands on that information? Yep, all of them. In another paper that was recently published in the New England Journal, Regulatory Innovation and Drug Development for Early Stage Alzheimer's Disease, this was in the March 28th issue a couple of weeks ago. The thing that makes my little heart beat with pride is the first author, Nick Kozauer, was my chief resident when I was residency training director at Georgetown. I baptized 2 of his 3 daughters. He called me one day laughing hysterically. And he said, we were looking at pictures of Maya's baptism, the second, with Sophie, his oldest. And she's pointing out pictures. Here's Mommy, here's Daddy, here's Nana, here's me. And then she pointed at me, dressed in my alb and stole, and said, Daddy, is that Jesus? I love Sophie. But what Nick is pointing out in this paper, that one of the regulatory challenges is, how do you decide when to release a drug if you don't know if it's effective? How long are the studies going to have to be? The vast majority of studies on quote-unquote Alzheimer's drugs run 6 months to 2 years. but the course of the disease can be up to 12 to 15 years. So we're not going to know, and it's not going to happen within the next 10 years, if ever. And finally, the ethics of early evidence, preparing for a possible breakthrough in Alzheimer's disease. Every time a journalist writes something stupid, like the new medicine slows Alzheimer's in mice, every geriatric psychiatrist phones, I want that new drug for my mother. Can we get that genetic test? The answer is no and no. The genetic testing is still in its infancy, except in the familial forms, which are very rare. Sporadic Alzheimer's, most common form, there is no genetic testing. A history in the family may increase the risk, but that's not the same thing as carrying a gene. So we run against a lot of different ethical dilemmas every time a new purported breakthrough is made. Stephen Post raises some good questions about whether or not to treat. And he notes that sometimes patients have navigated through a particularly rocky period, such as psychotic violence, or the patient has finally lost the insight that something is wrong. Would it be ethically permissible to return that insight, to return the patient to the point of psychotic violence? That's a tough one. And every once in a while, we think a patient may go on the medication and improve measurably. But is it a kindness to improve them to the point where they once again realize something is really wrong? Modest improvement or stabilization may not always be viewed as gratifying by the family. And the other important thing is that improvement on cognitive testing, on scales of word recognition or memory, rarely if ever translate into functional improvement, which is what we're really looking for. And what about suffering? Human suffering is unique because it requires consciousness and a degree of awareness in both the patient and in the family and or caregiver. Suffering for humans, and perhaps only humans can truly suffer. Pain and suffering are not synonyms. Suffering is not limited to the present because it relies on our experience of the past and it projects us into the future. We know that we will die. Sometimes suffering is a reminder of that fact. Suffering is not limited to the individual patient because we're able to empathize with those who suffer, and the family and others are dragged in to the patient's suffering, and they may in fact suffer more. Terry Schiavo did not suffer. Her family was in agony. And that was because of empathy. Oh man. The one who suffers is set apart. The one who suffers is seen as different by society. It reminds us of the certain knowledge that we will die. The more we suffer, the more we or someone we love will die. Pain may be a dimension of suffering, but it's not invariable. Sometimes it's easier to understand suffering when pain is present. But what is the meaning of the pain? The meaning of leg pain to someone who just won a marathon is very different to the meaning of leg pain in a similarly aged someone who has multiple sclerosis. One is a sign of triumph, the other, it's a reminder of incapacity. Suffering helps to define meaning in life. If there's meaning in life at all, then there must be meaning in suffering. Suffering is an ineradicable part of life, even as fate and death. Without suffering and death, human life cannot be complete. This from a man who knew suffering more than anyone in this room could. Victor Frankl. He lost his wife, his family, his manuscript in the camps. He watched people die, but somehow he maintained meaning throughout the awfulness of his suffering existence. Another man who suffered, and very publicly, and gave us an example of how to die, was John Paul. The but he wrote something very important in Salvifici Doloris. People react to suffering in different ways, but in general it can be said that almost always the individual enters suffering with a typically human protest and with the question, why? Why is always an angry question. One of the first things I heard in psychiatry training from a psychoanalyst is, try not to ask your patient why. Because it brings back images. Remember when you were in 3rd grade? You bold and brazen article, why did you do that? Or your parents asking, why the hell did you do that? Why did you take the car out after midnight? Why implies a little bit of anger. And that's the question we ask. Sometimes the only way we can pray is screaming at God, why? That's the one-word prayer, why? It's important. Suffering certainly raises the question of the problem of evil. How can God be all good if my mother's suffering so much? How can God be good if my daughter has a brain tumor? How can God be good if my pancreas is cancerous? Jesuit theologian Karl Rahner raises it that suffering is incomprehensible. And for many, this incomprehensibility is a litmus test for the existence or the goodness of God. This is a question that is never going to be answered. Whether you're Buddhist or Catholic or Jain or Sikh, it is not going to be answered. I promised you a little bit of practical stuff. How to be with a demented patient. This is the part that makes me crazy, certainly in nursing homes. How do you treat the person? Always respect a patient's personhood. Be professional. A very hard thing today. Do not assume a first name intimacy. Just because you like to be called Joni or Jack doesn't mean you have any right to go in to see an 83-year-old woman. Say, hi, Mary, I'm Joni. I'm going to bring you your lunch. It's disrespectful. I would tell the students at Georgetown, if you know that the man is a Jesuit, call him father or brother. We had a Vincentine monastery right next door. When one of the nuns is in, call her sister. Don't call her Anne. Place your role into context, which may mean reintroducing yourself every time you go into the room. People with dementia forget, sometimes very quickly. Speak to the patient first, and for God's sake, make eye contact. The person is a human. It's really amusing at communion time how many people come to communion and don't make eye contact with me. Or, when I'm on the other side of the paten, how many ministers of communion make no effort to make eye contact. It's a very important form of communication. Ask permission to speak with the caretaker. Even if the patient is profoundly demented. Mary, like Mrs. Jones, I'd like to speak with your daughter. Is that okay? And even if she doesn't give an indication, you've asked. Explain, invite, or ask permission before doing something, especially before tossing the patient in the shower. Old people are not cute. Dogs are cute. Babies are cute. Old people are not cute. They can be distinguished, they can be handsome, they can be fat. They ain't cute. So, don't infantilize them. Avoid the sing-songy voice generally reserved for kindergarten teachers. Only use first-person plural when necessary. Shall we eat our lunch? It's inappropriate. Would you like your lunch? 10 minutes. When I was up in Vermont, I got stat called to the nursing home. There was a man down there with severe dementia, but he was a wanderer. And he was trying to wander off the hall again, and all of a sudden he went berserk. So I go racing, the residents were all off site. So I got down there, And the man is fulminating. So first thing first, kneel down. He's in a chair. Kneel down, make eye contact. Hey, I'm Dr. Siberski. What's going on? And then he started. I was trying to go visit my wife. And I was going down that door. And this fat cow, and she was enormous, grabbed me by the shoulder and said, let's go to bed. Oh. I have a wife and I want to go to bed. I'm not going to bed with this slob. It's hilarious, but it happens all the time. Old patients are not sex objects. My twin brother, T, is a gerontologist. We don't know how that happened. We don't look alike, we don't act alike. But we both wound up with old people. We also both wound up working in prison. We kind of thought he'd be in one at one point in his life. But how many people will come in to an old man with dementia, an old woman, and say, hey, how's my boyfriend today? How's my girlfriend? When that man reaches up and grabs a part of the body that you do not want touched, it's not his fault. You're giving him clues. With the impaired insight, it's not sexual harassment, it's your stupidity for giving that patient clues. It's okay to touch. You're my boyfriend, you're my girlfriend, let's smooch. You got to be careful on that. Sometimes they'll still reach away anyway. But okay, I'm going to finish up here with 2 slides. This is the moral question. It's the moral question about treating those with dementia and about treating those who are dying. The test. Simone de Beauvoir, in her book, The Coming of Age. The true test of any society is how it treats the aged. Those who are no longer productive or useful. Those who may be an unwanted reminder of our frailty and our mortality. Will we fail? I started with Psalm 90. We're going to move down to Psalm 72. Do not cast me off in the time of old age. Forsake me not when my strength is spent. Which picture is going to characterize American society? This or this? Thank you.
So, do you still practice?
I was until I went to Australia as a tertiary, and then I moved from Washington to, I was out of the country for about a year. So I'm up in Massachusetts, and I'm just getting ready to try to apply for a license if I can afford it. Because I'm a geriatric psychiatrist. Do you know what the reimbursement is for geriatric psychiatric care? I'll tell you this, when I was in my last months at Georgetown, due to Medicare reimbursement, you can't charge the insurance, and the need to pay people who work in our department salaries. I couldn't afford to practice if I didn't have avowed poverty because I was bringing home $2,000 a month. So I got to talk to the provincial. I'd like to go back and do some consulting, etc. But I'm teaching a course at Boston College on the pastoral care of the elderly, the demented, and their caretakers. If I get a chance to practice, terrific. I love doing physical exams. I love teaching medical students. But there's a lot of stuff going on before we can figure that one out.
We need some big, broad thinking about this.
Here.
And
Well, we do. And I'm more than happy to travel anywhere to speak, except when it's snowing. Yeah.
The testimony talk available to us.
I was going to make some handouts. Life got really crazy before I've been out in the Midwest since Friday. So what I can do is, can they send it to you and I'll send you my slides? I can send Father Morrison.
You can send me your salon. You can send me your slides, and then my email address is through the John Paul Newman Center. It's on all the registration materials, my email address.
I'll send him the slides once I get back to Boston tomorrow night.
Oh, and we'll send them to me. Jake will put them on the website too, so. you can get
Right,
them.
okay, they'll be the narrative and maybe some of the comments. They will not be photography because those files are huge and they don't mail. Yeah.
I'd like to make a statement. I've gone to Lourdes on a few times. Many thousands of people have been cured at Lourdes. But unfortunately, the person that's cured never goes back.
Yeah.
Number two, suffering. I give a pamphlet of suffering to all my patients. Because suffering is a virtue. Nobody suffered more than our Lord. And I tell the patients, thank God you're suffering. You'll be spending less time in purgatory.
That's right. And even the question, my God, why have you forsaken me? No one suffers easily. Okay, well, thank you very much. It's been a great visit.